Hi guys, so for my video we'll be talking about a tracheostomy. A tracheostomy is an opening made into the trachea just below the larynx so a tube can be placed to create an artificial airway for the patient. While going over what a tracheostomy is, I will also be talking about the anatomy, physiology, pathophysiology, and the surgical intervention as a whole. As stated before, a tracheostomy is an opening made in the trachea to facilitate breathing. This is often done as an emergency, but is also performed electively to maintain a patent airway. Lying just in front of the esophagus, the trachea is a rigid tube about 4.5 inches long and 1 inch wide. It contains C-shaped rings of cartilage encircling the trachea to help reinforce it and to keep it from collapsing during inhalation. The open part of the C faces posteriorly, giving the esophagus room to expand during swallowing. When air is inhaled into the respiratory system, it first enters the nasal passages. Opening off of the nasal cavity are small canals, which are our sinuses. The airflow then continues through the nasopharynx, and the air that is inhaled is tracked downward through the larynx and flows into the trachea. At the lower end of the trachea, the inhaled air proceeds into the right or left primary bronchus. This then leads to the lower respiratory tract. A tracheostomy is indicated for patients who require emergency or elective airway management. They might be also placed on a ventilator or have acute or chronic upper airway obstruction. Upper airway obstruction may be the result of mechanical obstruction, redundant mucosa, tumor, foreign body, infection, or secretions. The obstruction may also be caused by congenital, neurological, or traumatic conditions. Diagnostic endoscopy procedures of the upper respiratory tract are commonly performed for direct visualization of the anatomy. Imaging studies, such as magnetic resonance imaging, computed tomography, and ultrasonography are commonly used to confirm or rule out disease or structure abnormalities. Local or general anesthetic will be given to the patient. In urgent circumstances, no anesthesia will be given, for any delay could result in irreversible hypoxia. The patient will be placed in supine with a folded sheet under the shoulders to help extend the neck. The arms are then secured to the patient's sides, and all bony prominences are padded. For the skin prep, you begin at the neck. You prep the neck, extending from the intra-articular border to the axilla and down to the table at the neck and shoulders. Folded towels in a sheet with small fenestrations are placed on the patient for the draping. For emergency tracheostomy, no drapes are using to help avoid loss of time. A transverse incision is made overlying the proximal trachea. For supplies, you might need a marking pen, a local, small basin, suction tubing, blades, tracheostomy inner cannula, catheters for suctioning out the tracheostomy tube, suction, and an ESU. The instrumentation that will be used is a tracheostomy tray. Basically, an incision is made over the anterior tracheal wall. The tracheal wall is then visualized and the tracheal incision is made. The tracheal incision is usually made between the third and fourth tracheal rings. The endotracheal tube is partly removed to the point superior to the tracheal incision. The tracheotomy tube will then be inserted. Bleeding is controlled and the tracheotomy tube is secured. Dressings are applied and the obturator from the endotracheal tube must be sent with the patient. For the dressing, a gauze dressing will be applied. There will be no specimen, and this is a clean contaminated case. I have attached a short video to help explain this. procedure, the circulator makes sure that the cardiac arrest cart is nearby before the surgery begins. Before passing the tracheotomy tube, the scrub person should also test the tube cuff for any air leakage. As a fun fact, the trachea and the tube bronchi with their many branches resemble an inverted tree, and that's why it's often called the bronchial tree.